Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Welcome back to the Dusty Muffins, the podcast where we tackle all the things nobody warned us about when it comes to hormones, health, aging, and trying to keep our muffins from getting too dusty. Today we're talking about a tiny little butterfly-shaped gland that can create an absolutely spectacular amount of chaos when it decides to stop cooperating, the thyroid.
Our guest is McCall McPherson, PAC, founder of Modern Thyroid Clinic, TEDx speaker, thyroid advocate, podcast host, and perhaps most importantly, a former thyroid patient who spent years being told her labs were normal, while she felt anything but normal. That experience ultimately led her to build one of the largest thyroid-focused practices in the country and become a leading voice in thyroid, hormone, and metabolic health.
If you've ever wondered why you're exhausted despite sleeping, why your hair is thinning, why your weight seems to have developed a personal grudge against you, or why brain fog has become your constant companion, this episode is for you. McCall, welcome to the Dusty Muffins.
I'm so excited and honored to be here. And I know we're going to share so much valuable information, but I have a feeling we're also going to have a lot of fun. So
Yes.
That is our goal. That is our goal every time we're on. And hopefully I will be able to get my focus on so that we don't have to listen to that ringing.
Yeah.
Sorry about that. So, well, McCall, I followed you since your very first podcast episode, and I think it was on Facebook. I somehow landed on your Facebook page, and then I often send my patients, I'm like, you need to go to McCall's podcast and go watch episode 2. You need to go watch episode 5. So I am very familiar with your story, but many people may not be if you are new to them. And I know your story started because you were the patient. Can you take us back to what life was like before you got diagnosed with Hashimoto's?
My journey had sort of this two-sided mechanism. One was years of not knowing, pre-diagnosis. And honestly, my most recent crisis that led me to this field was I was already medicated. Had moved from levothyroxine to Synthroid and was 27, and I was spending 16 hours a day in bed, not exaggerating. I was working my first job as a physician assistant and would come home from work every day at 3:30 and be flat on my back until I had to go back to work the next day. And weekends were spent the same. I was constantly in the cycle that I think so many thyroid people can relate to, of resting enough to recover from the day and trying to rest enough for the next day. And it's really hard to outpace that. I was losing my hair. I was overweight. I was depressed. I couldn't think straight. My libido was a negative 497 on a scale of 1 to 10. I could not function. And of course, I was already practicing medicine, not in the world of thyroid, but knew enough to know, hey, I just need to go back to my clinician. He'll fix me right up. I need a dose adjustment of my medication. So of course, that's what I set out to do. Saw him. He ran one lab, my TSH, which is the story of so many women. In fact, 80 to 90% of people only get TSH ran, and was sent away and said, hey, actually, we need to reduce your Synthroid your TSH is too low. And by the way, here's a prescription for Lipitor because your cholesterol is high.
Oh
So
my God.
At 27 years old.
At 27 years old, I broke down in his office and cried and said, look, if you take anything else from me, I will lose my job. I'll lose my relationships. And that, set me on a journey to get on the wait list for a physician who managed it progressively, and waited months to see him, but then was able to start to get my life back and started devouring every piece of science that I possibly could on thyroid. And he became a mentor to me as well. And slowly from that, Modern Thyroid Clinic was born. And now I get to help women just like me every day. Our clinicians get to do the same. And it's incredible work for sure.
That's awesome. What did he do different?
That's what I was going to ask.
What did he teach you differently? And so you were first a patient, and then it became a mentor for learning differently, I would assume, about the thyroid. What was it?
For sure. So, it's a few different layers. I think there are 3 big barriers that people struggling with thyroid dysfunction, undiagnosed or diagnosed, deal with. Number 1 is inadequate labs. So people are getting TSH, maybe TSH and T4, but most important hormones, free T3, get checked about 4% of the time, reverse T3 less than 1% of the time, and Hashimoto's antibodies, TPO and thyroglobulin. People need all of those, right? The second thing that he did different is he looked at my labs the same, in a similar way that we do now. What is optimal versus normal? Because the reality is people can be debilitated in a quote normal range. And then third, used more progressive medications. So 80 to 90% of people, 91% of people on thyroid meds are on levothyroxine based medications. That's kind of the drugs that everyone's familiar with. It's Levo, it's Synthroid, it's Tirosine, it's Levoxyl. And that doesn't work for a vast majority of the population. And when those medicines don't work for people, they're simply met with resistance and often being told it's not a thyroid problem because you're not getting better on medication. And there's so many flaws inherently in that too that I'm happy to go into. But I had hit all 3 of those barriers. So he addressed each of them independently, and it really changes people's entire landscape of their lives when they are dealt with those things in mind.
I was going to say, I think it's interesting because I took a course from WorldLink a couple years ago, and Dr. Roser did a really good job presenting all the data and how T3 or using liothyronine or even checking a T3, a free T3, is in all of the endocrinology literature, but yet none of it is in the guidelines. And it stops with TSH with a reflex if it's greater than 4.5. And it amazes me. And I find it, somewhat interesting conversation when you're optimizing women's thyroids and then they go back to their primary care provider, who then is, completely not informed, or even the endocrinologist who is completely against it. And I'm like, how do we have such a gap that the allopathic world, allopathic medicine, traditional trained, academic guidelines have completely missed looking at things beyond a TSH. Do you have any thoughts for that? Because in like trying to explain it to patients, like, you always preface, you're going to go to your primary and they're going to not be, well informed. And, this is what you're going to hear. Do you have any thoughts on how we missed all of this science? Have you been told your labs are normal, but yet you still feel exhausted, foggy, and gain weight simply by looking at a meal? Well, you're in good company. In midlife, normal isn't enough. You deserve to feel like yourself again. I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and certified menopause specialist. I deep dive into the areas often overlooked: hormone optimization, thyroid health, gut health, medical weight loss, including administering testosterone therapy for women. No rushing, no insurance hoops, just a blueprint back to a vibrant life. I'm accepting new patients in Virginia, Florida, and 5 other states. Book your clarity call at www.christinehartkressdmp.com.
Oh boy, do I ever have thoughts. Absolutely. I mean, what's so fascinating, Well, number one, the American Thyroid Association's guidelines have not been updated since 2014. So we're 12 years in at this point.
Guidelines.
Right,
Oh
right. So
Yeah,
I
all about
feel
'em.
like, right. I feel like thyroid is the orphan child left sitting out in the cold. No one is invested in this conversation, which is wild because it could single-handedly change the chronic disease burden in our country if it were properly addressed. And what's actually happening in real time in the data is there's two different kind of paradigms. One is we are seeing very clear data that free T3 is incredibly important, that combination therapy is very valuable, meaning medications that include, T4 and T3, inactive and active. I was speaking at a conference this last weekend and reviewed a study that says TSH plus T4 explain the variance of T3, your most important hormone, about 1% of the time. Meaning, if we are going to rely on TSH and T4 to tell us what free T3 is doing, which is how our whole medical system is set up, we can expect to be wrong 99% of the time, right? And the other layer that I think is wild, it sounds like you guys run across the same thing, is no one in medicine is more defensive about a category than thyroid. Like nothing makes people more angry. So I myself, and I even tell our clinicians at Modern Thyroid Clinic, we're going to do all of this. I want you to be extremely educated and informed. I want you to understand the top to bottom, the nuance of your treatment, your diagnosis, your labs. But I also want you to know, if you go back to your primary care doctor, your cardiologist, your endocrinologist, at some point they will look at you and they will say, who is this McCall lady? She is crazy, And meanwhile, we're doing the most conservative thyroid treatment. We're not over medicating people.
Right.
We're doing it all the right way, but it makes them really, really frustrated.
And I think sometimes too, first we come from that training, right? Where it's just that generalized training. It's medical school. My daughter's a third-year med student, and I think she's getting the same training. So like we did with hormones, we will have to undo all of that too with thyroid with her. And, and I go, for boards, this is what it is. In real life, this is what it is, but I think there's also those few people, like even with us and in the menopause space and with you in the menopause space too, where they're not, they're being too, don't want to say cavalier, but they are over treating. And then everything else gets this bad name. So now, you're being looked at like, even though like you said, your clinic is being conservative, they're still taking maybe somebody else that wasn't doing it conservatively and their patients were feeling terrible. And now it's kind of ruined it for everybody. Like, hey, I told you that this is what's going to happen if you just don't do it the way that we were taught to do it. Right.
No, absolutely. And in the world of thyroid, look, like T3 is life-changing. A progressive approach can single-handedly, I view it as changing, generational health, because when you change a woman's life, you change the life of her family, her children, her ability to show up as a grandmother. But if you overdo it, it can actually be dangerous. And it takes a lot to do that. But I've seen that more in my practice in the last 2 years than I've seen in the last 12 years. There are people that are being grossly, negligently over-medicated, and it's ruining it for everyone.
Yep. I have seen that as well. And it's been really difficult. And it's typically in some of the eyes of weight loss for women and getting them to lose some weight. So it was really interesting. Right. So then those of us that are doing it differently and trying to do it differently. And by the way, through Christine pushing me to do that, I've been hypothyroid since I've been 23 years old. And just this year did combined therapy. Yeah, I know.
So how has your experience been?
Feels great. It's great. Yeah. It's because it was scary. I'm like, that's not what I was trained. That's not what I was thought I'd. So, I dove in to all of the additional training, and I'm like, I have to do this differently. This isn't working for me. And as we get older, and I'd love for you to touch on this, our conversion of T4 to T3 also is an issue, and it doesn't do a great job of that as we're in midlife and we're aging in general. Can you touch a little bit on that? Is that what you see as well? Or maybe you don't let them get to that point because you intervened earlier.
Right. Yeah. And just to back up, like echoing what you were hinting at, in medicine, my training is never use drugs with T3 in them, only use drugs with T4 in them. If you put your patients on T3, you'll give them a heart attack or a stroke. So the underlying landscape of all of this is, one, we're not trained how to effectively use these medications, how to safely use them. And two, we're actually just trained to be really afraid of them, right? And so naturally, you were afraid. Naturally, so many patients who see their primary care clinician or whoever who are very anti-T3 get a lot of fear-based kind of propaganda rhetoric. So yes, let's talk about conversion. So just to clarify for people maybe who aren't in the medical field, conversion is taking your inactive thyroid hormone, it's called free T4, and activating it and converting it to free T3. So I always give an automotive analogy. I have no idea why I landed on automotive analogies in an aspect of medicine that serves 99% of women, but think about it like crude oil. We don't put crude oil in our car. We need it to take crude oil, make it into gasoline to put in our car to go somewhere, but you have to convert it. You have to activate it to make it usable. And the difficulty in that is we naturally produce mostly crude oil. So we have to convert in our body and activate it. We have to make gasoline from it. And second, the 91% of Americans who are on thyroid medication are on only crude oil hormone, meaning it is 100% dependent on their natural body's ability to take crude oil and make it into gasoline. And we don't do that well, number one, as a society, but as we age, we kind of get worse and worse at it. And I want to unravel this a little bit so people can conceptualize it. Our body slows the activation of our thyroid hormones on purpose. The closest analogy I can give that people would almost always recognize is, you know how when we're sick and we can sleep like 6 hours during the day and then 10 hours at night, like we're exhausted. Part of the mechanism of that fatigue is the halting of the activation of your thyroid hormones. So think about it as when your body wants you to lay down, rest, and recover, it halts the activation of your hormones so that you're tired. You lay down and it allows your body to recover. Now, in some mechanisms that cause that are sickness, for sure, but it's oxidative stress, it's inflammation, it's lower caloric intake, inflammatory food, protein restriction, over-exercise, poor sleep, stress, pregnancy, breastfeeding. So as we age, especially women postmenopausally, we can hone in on the fact that we are not as good at managing oxidative stress. That resilience massively goes down. As we age, we're not able to deal with that as much. And inflammation, oxidative stress, is the mechanism by which we age and disease occurs, right? So as we age, the activation of your thyroid hormones is getting lower and lower and lower. And how that manifests to people is literally just hypothyroid symptoms. So it's fatigue, it's brain fog, it's weight gain, it's hair loss, it's low sex drive, it's poor digestion, depression, cracking on the bottom of their feet, elevation in blood sugar, in cholesterol, increased risk for dementia, obesity. So all of that is happening under the surface. And it's so much of it is a mechanism by which we don't have enough T3. And what medicine does inversely is it teaches us don't use T3 with people as they age. It becomes more dangerous. And again, it can be like T3 can be dangerous. It is so easy to use safely if you know how to use it. This isn't some random occurrence where people have a heart attack or a stroke. Their T3 needs to be elevated significantly as you age, less significantly, but still pretty profoundly significantly for a period of time. And so, you know, we think of all the diseases we could prevent in people as we age if we simply just address this core hormone that so many of us naturally are becoming less efficient at making.
I don't know how all this is left out of our training.
I know.
Even endocrinologists, I mean, we only have a certain amount of hormones. They don't learn about testosterone, estrogen, progesterone, or some of the thyroid hormones. What is happening?
Right.
McCall, I'm sure there are people listening today. We mentioned like TSH who may not know what that is. Can we just maybe go back and start a little bit basic and explain the TSH?
Yeah, I love that. So TSH is your thyroid stimulating hormone. Okay. And it does that. That's its job. It stimulates your thyroid. It's actually a hormone that goes from your brain to your thyroid. And what's supposed to happen is, let's say you don't have enough thyroid output hormones, you don't have enough T3, you don't have enough T4. That message should get sent back to your brain and say, we need more thyroid hormones. Let's up-regulate production by increasing TSH, aka let's stimulate McCall's thyroid more to produce more thyroid hormone. Or inversely, when you have plenty, it should send a message back to your brain and say, we're great. We're great. We can take our foot off the gas pedal. We don't have to work as hard. We have plenty of output hormones. Lower her TSH. Okay. And so it definitely has a purpose. You know, medicine hanging our hat on the concept that that little feedback mechanism works all the time. And if we're only going to check TSH and sometimes TSH and free T4, we need to be very sure that that feedback mechanism is intact. And in the vast majority of people, it is in fact not, as the study, showed when it said it's only accurate about 1% of the time to predict T3 levels. And research, just standard research on average, says it's inaccurate 35% of the time. From there, your TSH stimulates your thyroid, and your thyroid secretes largely free T4, your crude oil hormone, a little bit of T3, right? That crude oil hormone, that T4, we want it to activate and become gasoline. We want it to convert to T3. It can do that. It can also just sequester there. Think about it like stockpiling crude oil in your garage. It just accumulates, especially if you're on a T4 based medication like levothyroxine or Synthroid and you can't activate it. Or that T4 can also shunt to an inhibitory hormone called reverse T3. So free T3, let's think about it simply, is shaped like your left hand. Reverse T3 is shaped like your right. When you hold them out, they're kind of a mirror image of one another. Same shape, opposite orientation. That is what reverse T3 is. And that allows it to actually bind to the same spot that T3 lands in. But instead of activating things like your energy, your metabolism, your mood, it just kind of sits there and doesn't let T3 bind and activate. So the higher your reverse T3 is, the lower T3 absorption you get. And people can kind of see, wow, this is a whole cascade of hormones here. There are lots of little things that can cause hiccups and make people not get to the end result that they need, which is T3 being able to absorb in adequate amounts. And so the answer to making sure that that whole cascade is working is just check everything, is look at it and analyze the numbers, because it's all very easy, attainable data that we get from a simple blood draw.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins. What was some of the reasons for that TSH being not something we shouldn't hang our hats on?
So can I tell you the number one thing that I see in my practice, which is kind of wild?
Yes.
Twofold. But number one, people don't convert. In big picture, all in all, they don't convert. They don't take that crude oil, they don't make it into gasoline, so they just stockpile crude oil in their garage. So I want to run through a situation with you that I think is happening with a huge percentage of people on levothyroxine, Synthroid, Tirosint, Levoxyl, Unithroid, the 91% of Americans on thyroid meds. So the worse you are at using that medication, the better your labs will look to a clinician who's not checking a full panel, which is weird to understand. But think about it. You're taking this T4, you're taking this crude oil medication. You can't convert it to gasoline. So what do you have? You have a lot of crude oil sitting in your garage. That crude oil is a potent influencer of your TSH. It sends a powerful message back to your brain that says, okay, we have so much thyroid hormone, lower this person's TSH. So their TSH lowers. So if your clinician checks only TSH, like me, it's going to in fact look low. It's going to look like you're over medicated. That TSH can be low. What would your T4 look like if you're taking it in a pill form and you can't activate it? It's going to look robust, right?
Yep.
All the while, this free T3, this most important hormone, this hormone that we're really trying to get to over here, is low because you're not converting crude oil to gasoline and you're stockpiling it. So in fact, when we are trying to manage someone's medication by TSH or TSH and T4 alone, think of all the millions and millions of people walking around being told their thyroid is fine, their medication doesn't need to be adjusted, and their symptoms are actually not due to their thyroid at all. How do they know this? Because your thyroid labs are normal when in fact their T3 is in the gutter.
Yeah.
Their gas tank's on empty.
Makes sense. Right. That feedback.
And it's always interesting that when you have someone that comes to you on T4 medication and you draw their labs and you look at it and, you know, their free T4 is like 1.8. And I'm like, and then their free T3 is less than 3. And you're trying to have the conversation that you actually have way too much T4. That's why your free T3 is very low and your reverse T3 is 24. And most importantly, and this is, I think, where women really start to listen, because I find that the number one complaint, like not complaint, but the number one symptom is that tell me about what happens between 2 and 4 in the afternoon. Can you function?
Mm-hmm.
Are you looking for caffeine, or do you feel like you just want to crawl under your desk? And in 99.9% of the time, they're like, that's what I'm feeling, and it's impacting my life in this way. And that's usually where, you know, there's a lot of buy-in for women that maybe there's a different way to approach this thyroid, and backing off on that T4 medication, adding a little T3 medication. And then when they come back in 6 weeks, they're like, oh my goodness, I'm not as cold. My hair's not shedding as much. And I can get through the afternoon. I can go sit out at the baseball field and not fall asleep.
Mm-hmm.
Yeah. You know, what's wild too is I read news studies every day in my inbox that come out on thyroid. And one came out, gosh, maybe 6-9 months ago that looked at mortality, disability, early retirement, socioeconomic status, osteoporosis, cardiovascular events between different groups, T4 levels that were higher and T3 levels that were higher. Higher levels, still within kind of the confines of what's normal, but kind of like you mentioned, you can get very high on T4, get high levels and still be, quote, normal. Higher levels of T4 were associated with increase in mortality, cardiovascular events, death, early retirement, lower socioeconomic status, less hours worked every week, and osteoporosis. We have 3 clinicians in this room. What are we taught about levels of T3? That it's associated with all of those things, right? Meanwhile, the same study showed risk reduction in mortality, cardiovascular events, heart disease, more hours worked, later retirement, higher socioeconomic status, and lower rates of osteoporosis, osteopenia in people with high normal levels of T3. Isn't that wild?
It is wild. Again,
but we are so comfortable putting people on so much T4.
Yeah. And the thing is, McCall, you are not like everything you've told us today. We were taught in our training. We were taught T3 is the active form. T4 floats around, is not active. It has to be converted to T3. So at what point then did we suspend belief and allow ourselves to be taught not to check T3?
They're like, and then that's it. And we were just so naive and dumb. We just didn't ask.
Oh my God, I feel so stupid. And when I look back at all my training and you're in ortho and they're like, oh, women get frozen shoulder between the ages of 45 and 55. Oh, women's suicide levels spike between 45 and 50. And no one was like, do you know why that is? Because we don't have any hormones between 40. Like, I feel so stupid for this just all going over my head for all those years. It's wild.
We don't know what we don't know.
We don't, right? And we're kind of indoctrinated with the systems approach. I mean, that's how medicine is. And for years, I was like, maybe this is like a PA thing. Maybe PAs are just taught that. But I've asked dozens of my MD friends and even our board certified endocrinologist who's like the chief clinical director of Modern Thyroid Clinic. Like it's all pretty consistent. So yeah, I don't know where we lost the map.
So how do you, I'm just still stuck at like, how do you teach the active form of T3, but don't check a T3 level? Yeah. I don't know. Sorry, and go ahead.
No, I was going to say, along with that, and then where do, clinicians go now that are coming out or that have been taught the old way and want to learn more about thyroid? So we have clinicians that listen to us. And so we try to give both patient information out. So we can do that too. Where can patients, find besides finding you, of course, where can they learn more? But more importantly, there needs to be more teaching on this progressive way of treating thyroid. So where is somewhere that clinicians can turn to get this information, this teaching, evidence-based and feel really confident about moving forward with treating thyroid?
I just want to know when McCall's going to do her class.
I know, because you have a course for patients,
right? Go into a segue in that.
When's the clinician course coming?
What's crazy is like it's tonight. I'm launching for the first time ever. I'm launching a clinician training.
You are?
I haven't even mentioned it on social media. So we're going to promo it this month, but it starts at the end of June.
Can you sign us up?
Asked me for this for years. Yes.
Like right now, take ours. Yeah.
Take our money.
You're like, take my money. Let's go.
Money, please.
Yeah. Years ago, I was like, I'm not going to do it. I'm going to just train my in-house clinicians. We'll expand. We're nationwide at this point.
Yeah.
It's still just not enough. Like there is not
it's
enough
like hormones,
access.
Right? It's like hormone therapy.
Like people need to know. And it is so incredibly nuanced. And unfortunately, it's not being done good enough in so many other trainings. And so I wanted to just teach people to get the same outcomes that we get. So I will keep you posted. I'm having a webinar literally tonight.
McCall, we call ourselves course whores. Like we cannot know there's a course and not do it.
We're like, well, McCall, like
y'all are so cute.
Clinicians and a little bit for patients too, just as an example, right? Do you find that patients feel dramatically better when their TSH is lower than what many clinicians consider acceptable? And can you give a little teaser of what you look for in a TSH level?
Feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
So my view of TSH and what I've found, I want people to think about in terms of the way it impacts how they feel every day. I want you to think about your TSH level as the energy going in to produce your energy. Okay, so think about it like, let's say your TSH is great, it's 1, and your output hormones are perfect. I mean, optimal, spot on. Guess what? People feel great. What happens if they retain optimal output hormones, but their TSH increases and now it's 4, it's 5? They are now using more energy than they are producing. So they are working too hard, putting energy in to produce the energy output, and they're in a deficit now. So it doesn't matter, in my opinion, and what I've seen in our data over 10 years, where someone's output hormones are if their TSH is too high. So I find most people need a TSH less than 2, ideally less than 1.8. At about 1.8, things start to change. People start to report symptoms, even if their T3 looks great, their reverse T3 looks great, even if everything is perfect. And I've found in the literature a few examples. What's interesting is a lot of it is psychiatry-based, depression-based. They tend to be more on the progressive side of like analysis and looking at things in a different way. And that also shows people need a TSH less than 2. And that correlates with what we see. So we want people always less than 1.8. Ideally, in a perfect world, closer to 1, certainly if they're pre-pregnancy planning, close to 1.
Yep.
Okay.
I love it. Oh my goodness. I'm dying over here.
I'm back excited about the class because
I'm so excited
to figure out all the McCall secrets through her podcasting.
There's a lot. Yeah, there's a lot, but we're going to like share them. Literally You can get them. It's literally the training that I take our own clinicians through. So
that's exciting.
It's everything.
Yeah, and
That
your
is
analogies
exciting.
are fabulous. You know, so many of the women I see, they'll come to me and they'll say they've been diagnosed with Hashimoto's. So I bet a lot of our listeners have heard of that. Do you mind just doing a 1-minute spiel on that?
Of course, yeah. So Hashimoto's is, in research, shows to be about 80 to 90% present in people with hypothyroidism. So a lot of low thyroid hormone production is caused by Hashimoto's. And what Hashimoto's is, by definition, it's an autoimmune disease. Your body gets a little confused. It thinks that your thyroid is a foreign invader and it mounts an immune response against it. And in that immune response, it starts attacking and eroding away your hormonal secreting tissue of your thyroid gland and replaces it with scarry inflammatory tissue that doesn't work as well. It's just not as efficient at secreting hormones. And from that, hypothyroidism manifests. Now, you can have those two things independently of one another. Hypothyroidism without Hashi without hypothyroidism. The big delineation is you treat them in two completely different ways. Hypothyroidism is treated with medication. You are supplementing a hormone that you're not producing enough of. Hashimoto's doesn't really get addressed with medication, but it can be influenced.
Yeah.
I've been in remission for over 12 years now. And, many of our patients have reached remission, not all of them, but even a reduction in antibodies with targeted methods can protect more of your thyroid gland. And honestly, I don't know what you guys think. I view it as a risk reduction for other autoimmune diseases.
Yeah.
So when you have one, you got an increased risk of 30% of others. The lower we can get those antibodies down, we can view it as a risk reduction for other more serious ones.
Yeah. And how do you do that, McCall?
Yeah. So it's individualized, but I'll give you like some of research-based favorite ways, and then I'll give you some of my own clinically based favorite ways. So in research, supplementing with selenium, selenomethionine are great ones. Vitamin D has a lot of data around it, and red light therapy. Red light therapy is shown to, reduce Hashimoto's and even Graves' antibodies.
Oh my gosh.
And
I have one.
improve conversion.
I'll
Yes. 6 inches, about 10 minutes once or twice a day. I got you. And then some of my favorite ways are looking at inflammatory foods. So what foods are creating inflammation in each kind of individual person. I love low-dose naltrexone. It's an incredibly powerful way to reduce antibodies, glutathione, and GLP-1s.
I get a question about the food piece, because we all hear gluten, dairy, soy are Hashi triggers, and I have recently been doing like gluten allergy testing because so many people don't want to give up gluten. If their gluten IgE is negative, would you still have them do a trial, or can I consider that done? I just been kind of experimenting because nobody wants to give up gluten. So I'm like, well, let me check and see if you actually have an allergy. What are your thoughts on that?
So I would say a couple things, just laying the foundation for someone to test in response to a food. They definitely have to have been eating it for months usually. So don't test gluten-free people thinking you'll get clarity, but I actually do IgG testing. So IgE is like, okay, I ate crab, I got hives, my tongue swelled, I need an EpiPen. It's this acute, really quick, which is meaningful. But a lot of people can tell when they have an IgG allergy because they get that physical response. IgG is chronic insidious inflammation. The half-life of it is 26 days, to give you like an idea how slow and low that inflammation is going to build up and leave. So it's so hard to like eat and see how you feel because it doesn't manifest until you're chronically exposed to it. So we do IgG testing. And I do like to test people before I withdraw them from something because y'all know thyroid people are tired. They don't want to go on an autoimmune protocol diet for the rest of their life if they don't need to. And most people don't, like let's just only take away the things that are going to make you feel good every day. Yeah. So I love the idea of testing. I would just switch to IgG. Yeah. Awesome. And dairy I find is number 1. Gluten is number 2. So you're on the right track. 3 days
Amazing.
ago. So
Oh,
people
this
can
has been
pre-order that
so
on Amazon
awesome.
or
Thank
your
you so
favorite
much for taking the
bookstore.
time
Take
to
back
visit
your
with us. Tell
thyroid.
us where people can
If you
find
wanna
you, can
find
follow
out more
you,
about it,
and
head to our website. We
can
have
work with
some
you.
special pre-order promos. And then you can always find me on social. I love educating on social and on my podcast, Modern Thyroid and Wellness.
Yes.
Thank you.
Yes. Amazing. Awesome. And
Amazing.
we'll link all of that in our show notes too. So it's easy for everyone to head right over to you. So, oh, awesome. Thank you so much.
If you enjoyed today's episode, please take a moment to follow, subscribe, rate, and review the Dusty Muffins wherever you get your podcasts.
Those ratings and reviews might seem like a small thing, but they help us reach more women who are sitting at home wondering if they're the only ones struggling with hot flashes, brain fog, sleep issues, weight changes, low libido, anxiety, or all the other delightful surprises that hormones can throw our way.
Share this episode with a friend, your sister, your partner, your colleague, your mother, or that woman who keeps saying she's fine while surviving on caffeine and sheer determination.
The more we talk about these topics, the more women realize they're not alone and they're not imagining it. There are often solutions available.
Until next time, take care of yourselves, take care of each other, and remember, life may make us dusty, but we're not done rising yet.